This conference will now be recorded.
All right, so let's cover chapter 32. We're going to cover the abdominal and genitourinary issues. All right, so let's kind of go over some AEMT stuff here really quick and go over the genitourinary process as well. So with this being abdominal injuries or issues, maybe medical trauma, whatever it may be, it's very hard to tell what's really going on underneath. A lot of our assessment is based on auscultation, listening to like the bowel sounds, listening to the abdomen, to really touching the patient, like feeling the abdominal cavity. You kind of see what it feels like. I mean, obviously, it's hard for us to tell specifically like what injury patterns you may have. So we use that mechanism of injury and suspected what we're going to find for these types. So the abdomen is the lower of the two major body cavities. So this extends from the diaphragm to the pelvis. It contains organs that make up the digestive, urinary, and genitourinary systems. And any of these organs may be injured, but some are better protected than others, depending on where they're located within the abdominal cavity and the thoracic cavity moving up, and what's protected, what's not. So injuries like this, injuries to the abdomen that go unrecognized or untreated, are the leading cause of traumatic death. We have a lot of different organs within our system, right? We have hollow and solid organs being very vascular, hollow organs being full of acidic chemicals that can do a lot of damage outside of that organ itself. So this is especially true in the pediatric patients, right? So these injuries are often overlooked, despite 10% of all trauma patients having some form of genitourinary injury. So if a high index of suspicion and prompt treatment are required, we have to literally take off the patient's clothes. We have to make trauma naked again, and actually take a look at their abdomen, palpate, listen. So look, auscultate, palpate, and see what we see. So in the abdomen, there are 4 quadrants, right? So divided into the 4 quadrants, or into quadrants, are 2 perpendicular lines that intersect at the umbilicus, as you can see here. Get out my... So we have one that comes down, one that goes across. Okay. So we have 4 different quadrants. We have the right upper, right lower, left lower. The quadrant location of bruising or pain can really delineate which organs are possibly involved in like a traumatic injury. All right, so keep in mind, and it's something you guys really need to understand as far as location goes. The right upper quadrant has the liver, the gallbladder, the duodenum of the intestines, and a small portion of the pancreas. This is our right upper quadrant. The left upper quadrant has the stomach, the spleen, and the pancreas, where the left lower quadrant has a large and small bowel and the descending colon. The right lower quadrant has portions of the large intestine, small intestines, including the ascending colon and the appendix. Right? So when we're palpating, and I went over this, I did go over this stuff with you guys in your trauma and medical assessments. Remember that the liver being located in the right upper quadrant, you should be able to feel approximately 2 centimeters of the tip of the liver. Okay, that portion. You should be able to palpate as they take a breath out. And you want to curl your fingers underneath the rib cage as they're doing exhalation to kind of ensure you can feel that. If it's inflamed, large, right, you'll notice that this would be more indicative of a liver type injury or inflammation of some sort. The appendix, being in the right lower quadrant, is found at a specific point. You guys remember what point that was called at all?
McBurney's.
Perfect, exactly, McBurney's point. So, yeah, I was writing down too. Awesome. So the diaphragm is the dividing line between the thoracic and abdominal cavities. Is the diaphragm. Okay, so the diaphragm being here. So we have hollow and solid organs as well. So a patient could lose all circulating blood volume into the peritoneal cavity. So peritoneal cavity being this area in here. A little high on that, but not using a mouse makes it a little difficult. Without any visible external bleeding. So that abdominal cavity, that peritoneal cavity all through here can take a lot of blood, right? So this is why we need to palpate. Do we feel ascites? Do we feel that rigid, hard abdomen that would be indicative of internal bleeding? But also looking at our vital signs as well, right? Looking at signs of compensated shock or signs of decompensated shock. So hollow organs are structures through which material passes through. They're more resilient to blunt trauma and less likely to be injured in trauma unless they are full of something. Solid organs include the liver, the spleen, the pancreas, and the kidneys. Remember that the kidneys are located to the liver, right upper quadrant here. The kidneys being down in this area here are called retroperitoneal, so that you can actually palpate more in the back than you would in the front. So right and left of the spine, lower part of the back, that's kind of where your kidneys are located, in the lower part of the back, more towards the flanks. So if we have a patient that has kidney damage of some sort, or let's say kidney stones, renal colic, that's where the significant pain is going to be. Obviously, then radiating down into the groin as well. So the best treatment for like a renal colic would be Toradol, be the best treatment, which should be coming to the A level at some point in time. So injuries can cause severe hemorrhage. Remember, solid organs are full of vasculature, so any one of these could bleed significantly if there's an injury. So the abdominal pain from penetration or rupture of a solid organ has a slow onset as well. So the different organs of the abdomen are contained in the peritoneum. So in figure A, in the retroperitoneal space, and B in the pelvis. Or peritoneum A, retroperitoneal space B, and C. So we have A up here. So you can see looking at the diaphragm, comes up and around. Liver, stomach, spleen out back here, right? Intestines, transverse colon, ascending colon. Then we look retroperitoneal, looking towards the back with the vena cava, aorta, the pancreas being more retroperitoneal, the kidneys, and then the descending colon being out back. This is more looking towards the backside, and the ureters coming down from the kidneys going into the bladder, right? Then we have down here the aortic vessels, uterus, rectum, bladder, sphygmoid colon as well. This is going to be more of the pelvic cavity what we carry down here. So there is some protection, but any one of this could bleed significantly, especially looking into the pelvis as well. So we talk about the symphysis pubis down here, the line I'm drawing on this down through. A lot of arteries, veins, major arteries, femoral arteries coming down through. If we have an open book pelvis, this splits apart at this location down here, we do have significant potential to take 3,000 ml, 3 liters of blood that could potentially leak out into the pelvic cavity. And really, you would have no indication of that significant bleeding unless you actually took vital signs, looked at the status of shock. Do you see the line now, Rosa? You got it?
Yep, now I do.
Yeah, it's kind of hard because it's like a red line. I'm drawing through red here, so I keep changing the colors. So that would be the open book pelvis fracture that we talk about, or any kind of fracture on the iliac or iliac crest, things like that. The things that could fracture open that could cause significant bleeding if one of these is severed. That's why it's so important that we're doing our trauma assessments or we're doing that rapid assessment. This injury down here is considered a significant finding. This is something we need to stabilize right away, not something that we could pass over and get on a secondary assessment, right? Pelvic fractures are stabilized right away, whether you use a pelvic binder, a reverse KED, sheets, whatever you may utilize, it has to be stabilized. One of the things we're bringing into the field now, which is nice, is portable ultrasound, which is going to be a game changer even for the paramedic level coming here in the future. to be able to do fast scans, to be able to see free-floating fluid in the abdomen. So the genitourinary system, the urinary system controls the discharge of certain waste materials filtered from the blood by the kidneys. So the reproductive system controls the reproductive process, which obviously life is created. So the general pathophysiologic concerns would be hemorrhage, which can occur with external or internal blood loss. And I'll show you guys in the picture next, where you may see a closed abdominal injury and the bruising below. So irritation of the nerve endings do occur as well. Pain is localized if the extent of the contamination is confined. So pain becomes generalized if the entire peritoneal cavity is involved. So as you're palpating, is it a localized pain? And once you get to the pain, is it rebound pain, like pressing down and coming back up, to constant pain? What does the pain feel like? Sharp, dull, pressure as we're going through, getting that number scale 0 to 10. How do we lie with that, right? The pain in the peritonitis is an intense, potentially life-threatening inflammatory reaction where you have inflammation of the peritoneal cavity. So the first signs are severe abdominal pain, tenderness, and muscular spasms with the peritonitis. So pneumoperitoneum would be a free air, pneumo air, peritoneal cavity, which would be free air in the peritoneal cavity, which may occur as a result from rupture of a hollow organ or a perforated peptic ulcer or recent abdominal surgeries or rupture of the abscess as well. Closed abdominal injuries, as you can see the different discoloration here, right? That would indicate significant bleeding underneath, some bruising. So compression injuries typically caused by poor placed lap belts. We talked about that in the previous classes. Deform the hollow organs, increasing the pressure within the abdominal cavity. With that, hollow organs can rupture. Deceleration injuries also occur when a person or the vehicle in which the person is traveling strikes a large immovable mass. So they have that deceleration injury where they hit that wall, but they keep going, right? The deceleration injuries that happen with that. So what are the three, and we talked about this before, what are the three impacts that we have again in a motor vehicle crash?
Vehicle versus object?
Yep, vehicle versus object, then what? That's number one.
Person into vehicle,
Yep, and then the third one?
then person into vehicle,
Yep.
and then your internal organs into your skeletal system.
Exactly. I like what Matt O'Connor said, guts to body. That internal contact. So that's exactly right. So when we have these injury patterns, again, looking at abdominal, we need to kind of plan for that and say, okay, the mechanism of injury is here. They're wearing this. I suspect this. So crush injuries result from external forces at the time of impact. That crush injury. Solid organs are the greatest risk, being crushed. Then we have damage. Then we have significant bleeding in the abdominal cavity. Shearing may also cause tears as well. So we talked about like the aortic shear, the shearing as well from that significant impact. So as you can see, looking at lap belts here, right, you can see incorrect versus correct positioning. So a lot of times they'll wear them over versus under, or they're supposed to be down here, the under pattern. So injuries from seatbelts and airbags. So seatbelts are cause blunt injuries to abdominal organs. So if too high, it can squeeze the abdominal organs through great vessels against the spine. Pop. Used alone, diagonal shoulder safety belts can cause severe injuries to the upper part of the trunk. So we have to have the abdominal belt, and we have to have the shoulder belt coming across. Small children and short people who are in the front seats of automobiles may be at risk for injuries when the airbag is deployed. As you can see here, this being the airbag. Most everybody should know what that is. All right. So we look for signs. We inspect beneath the airbag for signs of the steering wheel. These airbags come out at an excess of 300 miles an hour. They can be single stage or two stage, so they could go off a second time. What's going on my computer? Apparently wants to do some more verifications. So when you're in the vehicle, look up here, okay? Right? Look at this. Look at the windshield. Look for starring, right? Head injuries. Look at the steering wheel itself. Is the steering column down here, is this bent? Are these bent here, the wheel itself? Look for any kind of potential for more injuries. And also look down below, down in this area as well. That would indicate potential for some for like pelvic injuries, things like that, especially if the knees got caught in a head-on collision here, right? That force would then drive this direction into the person that's sitting over here, right? The patient itself, causing that significant injury and potential for femur fractures going into pelvic fracture with that force. All right. So keep that kind of stuff in mind. Look for the indicators that are there when you inspect the vehicle. Now, a lot of times, if you're working for like private EMS, a lot of times they'll actually get the patient out and bring them to you. I get that. There's nothing wrong with that. But still, you as a senior provider, the higher license level, need to take a look at that vehicle. Whether you go in there and you grab some quick snapshots with your phone or take a good visual look, you have to see those patterns. You have to look for everything that's there, because that's going to give you that mechanism of injury and potential for or where the injury patterns are going to be. Does that make sense to everybody? Take a look. All right. A lot of this stuff should be reviewed for everybody here anyways. All right. So open abdominal injuries, gunshots, stab wounds. So gunshot wounds involve injury to the small bowel, the colon, the liver, vascular structures. In stab wounds, the liver, the small bowel, diaphragm, and the colon are frequently injured. Right, so you got to kind of pay attention to what those are. If we have remember, if there's an object that's currently impaled, please not just pull those out. Stabilize in place and continue. Right. If you have a GSW, we got to look for entrance and exit wounds. Right. Usually the exit wound would be bigger than the entrance. And remember that if you don't have an exit wound, the bullet is still somewhere inside where it ricocheted. If you have a through and through, but it comes through one end and then let's say it goes in the upper part of the abdomen and then it comes out closer to the buttocks, it ricocheted off something inside. Okay, causing potential for a lot more damage internally. So I want you guys to keep that kind of stuff in mind when you're doing your assessment. So in evisceration, this goes all the way through the skin and the muscle layers, through the fascia, resulting in bowel protruding through the skin. So as you can see in this area here, this can be done as simple as a laceration causing the organs to come out, or a patient just had recent abdominal surgery, and I've seen patients sit down and they sneezed, ripped open the sutures, and out come the abdominal organs. I've had that actually happen more than they probably should have seen. Has anybody ever been to an evisceration before? Simple ones like that. Have ever seen that before? At any point in time, this can be common, where organs protrude through the open area. Not one that survived yet. So I've seen them. Actually, the last one that I saw was actually Justin was actually in Lebanon. We had one when I was running with them years ago. One of the ones I went to, and the guy was literally just got back home. He was home for a couple of days with after getting abdominal surgery, and he sneezed and then out they came, pop. So when you get there, to address this, we have to we use a moist, sterile dressing. Please do not start putting these things back in. They have to go back into surgery to properly place them back. But moist, sterile dressing over the top to prevent them from drying out and do the best you can to prevent any form of infection. So the diaphragm, abdominal organs may be pushed outward up into the thoracic cavity for specific structures. Patients will exhibit dyspnea and feel short of breath and may have abdominal respiratory sounds, and may also have an abdomen with a sunken, like concave anterior wall, would be like the scaphoid abdomen. Patients with a ruptured diaphragm may become very anxious and short of breath if placed in a supine position. So injuries to the diaphragm will then cause signs and symptoms of ventilatory compromise. So look for those patterns, look for those different patterns that are there. So kidneys, which is the most common injured organ of the genitourinary system, as you can see, like football, sports are some of the biggest ones that you have with kidney issues as well, with injuries. So the blunt renal trauma results in the kidneys becoming compressed against the lower ribs or the lumbar spine. So a ruptured kidney causes significant pain on inspiration in the abdomen and the flank area. So if you have that, look for the bruising, look for that pain. Penetrating renal trauma is most or more likely to be associated with an injury up to the upper liver, to the liver itself, the lung, and the spleen, where injuries to the kidney are rarely occur in just isolation on its own. Significant trauma, football being one of them, whether they land down in this direction here, or they have an illegal hit, which is, I call it legal hits, but definitely illegal hits to the back, where they have injuries to the kidneys out back there as well. Excuse me. So penetrating renal trauma most likely associated with the liver, lung, spleen. Injuries to the kidneys rarely occur in the isolation part of it. Just kind of reiterate that part. Suspect kidney damage as well with abrasions, lacerations, contusions, or hematoma to the flank region. So if you expose and you see those, suspect there's kidney damage as well. The penetrating wound in the region below the rib cage, above the hip or the flank in the upper abdomen, or fractures on either side of the lower rib cage or of the lower thoracic and upper lumbar vertebrae. So if you have those injury patterns that are there, or suspected injuries, suspected kidney damage as well. The liver penetration or rupture may quickly lead to signs of shock. Remember that the liver is very vascular. Must be suspected in all patients who have right-sided chest trauma as well as abdominal trauma and referred pain to the right shoulder. The spleen has potential for rupture is much higher if the spleen is enlarged, right? Or mononucleosis or underlying disease. Large amounts of blood spill into the peritoneum as well. And suspect a spleen laceration with fractures of the 9th through the 10th rib on the left side, or when a patient reports left upper tenderness, hypotension, and tachycardia. So the pancreas typically takes a high energy force to damage the pancreas. So patients present with vague upper mid abdominal pain that can radiate into the back. So if you have that mid abdominal pain radiating to the back, potential for a pancreatic issue. May also develop peritoneal irritation hours after the injury as well. For the intestines and the stomach, the intestines are most commonly injured from penetrating trauma. So blunt trauma to the abdominal wall commonly cause injury to the duodenum, which may present as back pain. Contamination of the retroperitoneum with the duodenal contents may produce abdominal pain or a fever. So now we have those contents leaking out into the abdominal cavity, causing that significant infection. So that our body will start developing a fever to help fight some of that infection off. So abdominal pain, nausea, and vomiting may also develop, although as well. Most injuries to the stomach result from penetrating trauma that we have. Falls onto sticks or anything else with that. So most injuries to the stomach or trauma to the abdomen may cause injury to the small bowel, the stomach, the large intestines, where rupture of the stomach causes rapid burning epigastric pain, rigidity, and rebound tenderness. So you have to make sure you really palpate the abdominal cavity, get all 4 quadrants, 2 hands, push down, back up, feel that if they have the significant pain, right? So remember, rupture of the stomach causes rapid burning epigastric pain, rigidity, rebound tenderness, right? If you have that. So I'm trying to answer one of the students. Apparently, Sean Edelman can't get into the class. Stand by for a minute. Should help you in. Let's see. Let's see, Sean. Not sure why you can't get in. Everybody else. Did anybody else have a problem logging in at all? It's not recording.
This conference will now be recorded.
All right, where are we here? Let's see. All right, so the urinary bladder. So usually associated with pelvic fractures, right? So we have a urinary bladder issue, potential rupture. So as you can see here, remember that the contents inside the urinary bladder are very toxic, especially if it leaks out into the pelvic cavity. So bone fragments, as you can see here, can actually rupture and cause the urine to leak out, along with pelvic fractures, things like that, or a ruptured bladder. So that's something that we don't want to have happen. We got to be able to pick up on that. So to palpate the bladder, obviously lower quadrant palpation, lower quadrant. With that. So should be suspected in a patient with a trauma to the lower pelvis or abdomen. So motor vehicle crashes, seatbelts, significant fractures here could be like dashboard issues as well, having that force drive up that direction here, causing the femoral head. Usually it'll be a fracture here on the femoral head, but sometimes if this is strong enough, this will either dislocate and pop out this direction here, or you'll have that fractured pelvis down below, causing that fragmentation to cause the rupture of the bladder. So blunt injuries to the lower abdomen and pelvis often cause rupture to the lower urinary bladder, and then urine may also be spilled in any part of the abdominal cavity, leading to intra or extraperitoneal or retroperitoneal rupture as well. So the external male genitalia, some of the things that we come in contact with is testicular torsion. Very, very painful. These patients require significant pain management, where the testicle twists. So injuries to the testicle or scrotal sac is the loss of fertility is the major concern. So patients that have testicular torsion or any kind of testicular damage need to be transported to a place that has urology so they can take care of this surgically. If they can't untwist it by hand, then they have to go in surgically and untwist it. There's only a matter of time. These are considered life-threatening injuries because of the fact they can, if it stays with torsion for a long period of time, they can no longer have kids. They will lose that fertility, loss in fertility. One testicular trauma can result in simple contusions, ruptures of the testicle, and in rare cases, torsion of the testicle itself. So have a high index of suspicion for other associated injuries in cases of obvious penetrating trauma. I've seen this as simple as males riding bicycles and just sitting on the seat and having them twist and go into torsion. Or if they roll over wrong at night and as they're sleeping as well. I've had patients with that as well. They've been diagnosed with testicular torsion. Actually, I had one over the summertime. Penis injuries as well. So you could have a fracture. So this may result in blunt or penetrating trauma, but also may arise from sexual behavior or self-mutilation as well. So a fractured penis may also occur when an erect penis is accidentally impacted against the partner's pubic as well, or a pubic symphysis or bent too far via self-mutilation. So penetrating trauma usually is a most often result is gunshot wounds. So as far as the female genitalia goes, uterus, ovaries, fallopian tubes are rarely damaged because they are small, deep in the pelvis, and well protected by the pelvic bones. Penetrating trauma to reproductive organs may result from stabbings to the lower pelvis or gunshot wounds. So as pregnancy progresses, the uterus enlarges substantially, and rises out of the pelvis, becoming vulnerable to penetrating and blunt injuries. So expect signs and symptoms of shock with pregnant patients. And if possible, ask the patient if she is due or when she is due and report that date to the hospital staff. How far along are you and when is your due date? You can kind of see which trimester that they're in as well. Supine hypotensive syndrome is where the patient should be carefully placed on her left side, as that the uterus will not lie on the vena cava. If we have that pressure against the vena cava, it'll put them into a significant hypotensive syndrome. And just by turning the patient to their left side, takes that infant or the fetus inside and takes it off those vital organs, allowing blood flow to continue. Hi, Sean. I see you made it.
Hello.
Let's see. So determine the possibility of pregnancy as well. Injuries to the female genitalia can also include all types of soft tissue injuries. Keep in mind, though, it also could be a case of rape as well, causing significant trauma down there. So keep that in mind, that it could also potentially be evidence for a crime scene as well, if that is the case. So if there is significant bleeding, we don't pack anything inside. Remember, we just kind of collect it. If you have a female provider, especially if it is a rape case, it's always good to have a female out back with that patient if you can. But again, if you're a male and you're an AEMT and it has to go with ALS and you're the only ALS provider on scene, you have to take it. So as far as vascular injuries go, blunt trauma can cause injuries to the vascular structures in the intraperitoneal space, often masked by other injuries. So again, you have to palpate and look. Don't be distracted because of something else that's there, because some other injury may be more severe in that case, causing you to go in tunnel vision into it the wrong direction. Significance of the injury depends on how many vessels were injured and the length of time that has passed since the injury occurred. So assessment findings differ depending on whether the bleeding is contained or there is still an active hemorrhage. Patients that have significant bleeding like this here call for ALS for paramedic level, so we can give TXA potential as well to help control some of that bleeding that's there. So a common sign of bleeding in the abdomen is rigidity with almost like a board-like feeling of the abdomen. Occasionally, you'll find a periumbilical bruising or ecchymosis, and that's called Cullen's sign, right? That periumbilical bruising, right? What is Gray-Turner's sign again? Do you guys remember that one? We talk about Cullen's and Gray-Turner as we do trauma assessments. Does everybody remember Gray-Turner's sign?
For the pancreas?
No, Gray-Turner's go to the flank. So that'd be significant, it could be, but significant bruising on the flank though.
Kidneys.
So, yep, so that'd be Gray-Turner. So we document, when we're going through our assessment and documentation, we palpate all four quadrants and also document was there any retroperitoneal pain, Gray-Turner's, Cullen's as well. Abdominal aortic aneurysm or AAA might have developed and have become worse due to abdominal trauma, if there is one there. So it's a good idea to ask them, do you have any history of aortic aneurysms? Rectal bleeding is also a common complaint caused by sexual assault, rectal foreign bodies, hemorrhoids, colitis, and ulcers of the digestive tract. So a patient assessment, Obviously, maintain professional appearance. Remember, expose only what you need to expose and cover what has been exposed back up again. Whenever possible, have the AEMT of the same sex in the back of the ambulance. Let me get into our scene size up. So scene safety, BSI, number of patients, indicators, early spinal precautions. I'm going right down through. If the wound is penetrating, remember, inspect the object of the penetration as well. And then the patient may also avoid discussing the injury to avoid undergoing a physical examination. So try to get the information you're looking for. Do an assessment. If it is something that is a wound that's penetrating and the object is still there, stabilize the object in place. If it's a very long object, then we need to cut it down to be able to get the patient to go. Remember the XABCDEs as well, and treat immediate threats, any life-threatening conditions, femur fractures, pelvic fractures, external bleeding. That's not like a simple laceration, but like, arterial bleeds, things like that need to be tourniqueted off or significant pressure placed. Remember to keep the airway clear of vomitus, so ABCs. Assess breathing for adequacy, rate, rhythm, and quality. Evaluate the patient's pulse, skin color, temperature, condition, and treat for shock according to your protocols. Early assessment of the abdomen as well, perform a full body rapid scan, and if you find a life-threatening problem during the scan, stop and treat it. Examine the abdomen closely, looking for decap BTLS or hemoperitoneum as well. So is there any blood, ascites, feeling that rigid abdomen? Do we feel that as part of our assessment? History taking, determine and investigate the chief complaint, what is going on, and also look at the mechanism of injury and further investigate that. Remember, we can have patients that can have deferred pain because something else may be more severe. Okay, it doesn't mean that they don't have an injury. If the patient is not responsive, attempt to obtain a sample history from their friends and family members and ask the patient if they've experienced nausea, vomiting, or diarrhea. Ask about the appearance of any bowel movements and urinary output and check for any blood, urine, black tarry stools called melena, or blood in the stools as well. So the incidence of repeated or previous injuries or illness involving the genitourinary system can also help determine the extent of the current injury and possibility of the MOI. Whether it be like a sexual act to a traumatic act to whatever it may be, we're trying to get the information out to find out how we're going to be able to treat this. As far as the secondary assessment goes, I may need to perform en route. You get vital signs, 5 to 15. Focus assessment on the isolated injury of the patient's complaint of the body region affected. Abdominal pain can be treated with pain management, right? However, can you treat it with PO Tylenol, or does it have to go the next route? Does it have to go up to IV Tylenol if you carry it, to narcotics? Provide the privacy as needed. Wait until you're in the back of the ambulance. So please do not start exposing your patient out in the home, right? Take a quick look at the abdominal area, palpate, get them out the ambulance. We need to expose more than we do that in the back of the truck, right? Unless it's something that we have to do on scene right away, but based on your assessment. For the patient without suspected spinal injury, should be allowed to stay in a position of comfort, whether it be on their side, knees bent, whatever it needs to be. What makes them more comfortable? Comfortability reduces pain. For patients with spinal injuries, we obviously place padding, blankets, pillows under the patient's knees to help elevate the knees up. You can elevate the knees even though they are in spinal precaution. Maintain a high index of suspicion and provide early treatment for shock, looking for your vital signs. Note any decap BTLS and hematuria. Note if there's any blood in the urine. And look at your pain assessment, somatic pain and visceral pain as well. So as you're palpating, what does it feel like? How does it feel? Does it radiate anywhere? Looking at your OPQ-RSTs as well, how long it's been going on for. Then we're going to get to our reassessment, where the patient's primary assessment survey, vital signs, looking for that trending, see how things are going. Are vital signs coming down? We're giving fluids. Are we pulling them out of shock, or is it becoming decompensated? Looking at patient's skin color and temperature. Are they becoming pale, hypothermic, diaphoretic? Are they becoming more tachypnic, more tachycardic, right? Document the results of the physical examination and be cautious and diligent when dealing with patients who refuse transport to the hospital. Any patient with abdominal pain needs to be getting a 12 lead. Doesn't matter, 12 leads. right? We should not be focusing just on the 4 for abdominal pains, because even significant abdominal pain, if it's not traumatic related, right, can also be a STEMI as well. So I want people to really push to get 12 leads completed on patients with abdominal pains. Please not just do the 4, right? You can do a 4 quickly, but at least end up doing a 12 at some point in time within 10 to 15 minutes of contact. Assessment and management for specific injuries. A patient presenting with blunt injuries need spinal mobilization, restriction, high flow oxygen. I'm surprised this is actually still in here, but the pneumatic anti-shock garment, PASG, we do not use those anymore for unstable pelvises. That was something that was back in the late 90s when I first started EMS. We had those. Those are the mask trousers. We just don't have those anymore. But they may. I know out west they probably still use them. Over where we are, they don't have mask trousers anymore. So we have pelvic binders, SAM binders, things like that we can utilize. Rapid transport to the closest, most appropriate facility and provide emotional and psychological support en route. For closed blunt abdominal injuries, pain is a principal complaint for patients with abdominal injuries. Please treat pain. Right? What can pain do? I just saw Justin's thing. I took one of those off my whole frig last year. If you still have them laying around, bring one in so the class can see it, Justin. I don't have any because they've been off the trucks for so long. But if you have one laying around, people want to see what it looks like, more than happy to show it off.
Yeah, I'll bring it down with me this week.
Awesome. It'd be great for the class to see an old relic like that. Yeah, so Matt O'Connor said elevated vital signs. Yeah, exactly. Okay, we're looking for that. Looking at the signs of shock. So tachycardia is the most common sign of significant abdominal injury. Treating that pain, right? So pain elevates vitals, like Matt just said, right? Elevates the vital signs so we can control that pain. I didn't say snow the person, right? But control the pain. Give enough medication, calling for a paramedic, give enough narcotics, whatever it may be, ketamine, whatever you need to utilize to treat that pain and not to bring the pain level down so it's tolerable. We don't want to make them pain free. That's not our goal. Our goal is to reduce the pain to help meet the physiologic state we're looking for, right? Reducing. The signs and symptoms of the blunt injuries include bruising or other visible marks whose locations should guide you or guide your attention to the underlying structure, right? So we have Kerr's sign, Gray Turner sign, Cullen sign. So I'll kind of go over those with you guys really quick. Kerr's sign is pain in the tip of the left shoulder due to bleeding in the peritoneal space as a result from injury to the spleen. So splenic injuries, pain in the left shoulder is called Kerr's sign. Gray Turner sign is bruising in the right upper quadrant, left upper quadrant, or flank that suggests injuries to the liver, spleen, or kidneys. Look at that Gray Turner sign. And Cullen sign is bruising around the umbilicus that is predictive of internal abdominal bleeding. Then we have guarding, where the patient intentionally or unintentionally stiffens the muscles of the surface of the abdomen. Then we have closed abdominal injuries that may initially appear as abrasions to the surface of the skin. These 3 things here, I guarantee you're going to see again on the National Registry exams as well. So know these different terms. Kerr's sign, Gray Turner sign, Cullen sign, right? Very big on looking at abdominal trauma. So blunt injuries as well. Patients with blunt injuries or abdominal injuries may also have one or some combination of severe bruising of the abdominal wall, lacerations of the liver and spleen, rupture of the intestines, gallbladder or stomach, tears in the mesentery, rupture of the kidneys or revulsion of the kidneys from their supporting structures, rupture of the urinary bladder, severe intra-abdominal hemorrhage, peritoneal irritation and inflammation in response to the rupture of the hollow organs. So if you suspect injury to the diaphragm, focus on airway, breathing, and circulatory status. You also want to immobilize any patient who has sustained a blunt abdominal injury. Monitor for indications of shock. Remember, looking for that compensated shock, the tachycardia, tachypnea, potential going into hypotension, looking at your mean arterial pressure, looking at your end tidal. Look at all that stuff together pulse oximetry. Are we bleeding out? Are pulse ox dropping down? We're losing those red blood cells. Keep the patient warm. Warm is good. Again, IV therapy as well. We don't talk a lot about this in this program through the slides, but intravenous access. Anybody with abdominal pain should be getting IV access unless they absolutely refuse. And if they do, explain the benefits and risks behind it. Assume that the object has penetrated the peritoneum, entered the abdominal cavity, and possibly injured one or more organs. So if the object is still in place, do not remove it. Stabilize it in place. Initiate 2 18-gauge IV lines or larger, or follow local protocol. Increasing blood pressure can increase internal bleeding, so fluids may be given in a volume to maintain perfusion to vital organs. And how do we measure perfusion again? Make sure the organs are being perfused. How do we measure that perfusion status for bleeding? Make sure they're getting enough blood. Pulse ox, end tidal, and blood pressure, right? Adjusting our blood pressure. And specifically, what part of the blood pressure we're looking for? Make sure we're perfusing. We got systolic blood pressure and the MAP. Exactly, mean arterial pressure. Are we meeting the MAP we're looking for? Right, almost done with this presentation, and then we're going to do the next one. Abdominal evisceration. So again, do not push down on the patient's abdomen. If there's stuff coming out, please leave it out. Don't push it back in, don't push down. Perform a visual assessment. Never try to replace an organ that is protruding through the abdomen. Cover it with a sterile gauze compress, moisten with sterile saline solution, and secure it with a dry sterile dressing over the top. Provide other emergency care as needed. IV therapy, get them to the hospital. Cardiac monitoring. So the open abdomen radiates body heat rapidly and must be covered. You need to cover these up. Cover the wound with a moistened sterile dressing with an occlusive dressing, depending on local protocol. Secure the dressing with a bandage and secure the bandage with tape. We do have abdominal trauma pads, so the big trauma pads in the ambulances. So utilize those to cover these up. As far as kidneys go, signs of shock of the injury associated with significant blood loss, blood in the urine. So treat shock and associated injuries that are there, IV therapy, cardiac monitoring, and provide prompt transport to the hospital. Urinary bladder, suspected possible injury of the urinary bladder if you see blood in the urethral opening or physical signs of trauma on the lower abdomen, pelvis, or perineum. The presence of associated injuries or shock will dictate the urgency of transport. So again, you have to reassess our vital signs every 5 minutes, look for that trending, are they going in a direction of shock or not, right? What you see, what you visualize also helps you as well with your determination. The external male genitalia, general rules, injuries are usually very painful. I made the patient as comfortable as possible. Use sterile, moist compresses to cover areas that have been stripped of skin. Apply direct pressure with a dry, sterile gauze dressing to control the bleeding. Never move or manipulate impaled instruments or foreign bodies in the urethra. If possible, always identify and take avulsed parts to the hospital with the patient. Manage blood loss as priority in amputation of a penile shaft. Never apply a constricting device to the penis to control bleeding. So do not put a tourniquet on. Suspect testicular torsion when there is a direct trauma to the testicles. All right. And never attempt to move the tight objects around the penis, testicles, or both should be made in the field. So no attempt should be done for those. And to finish up, female genitalia, lacerations, abrasions, avulsions should be treated with moist sterile compresses. Use local pressure to control the bleeding and a diaper type bandage to hold the dressing in place. Remember, never pack anything in. Leave any foreign bodies in place and stabilize them with bandages. Bleeding can usually be controlled by local compression. Contusions and other blunt injuries all require careful in-hospital evaluation. So urgency and the need for transport will determine by the associated injuries, the amount of hemorrhage, in the presence of shock. So again, vital signs and trending. If you believe your patient has been sexually assaulted, do not examine the genitalia unless obvious bleeding requires you to apply a dressing. Because we have to make sure everything stays in place so they can have the rape kits done at the hospital by someone who's certified and trained to do so. All right, with that being said, I'm going to give you guys 10 minutes.
This conference will now be recorded.
All right, so let's talk about orthopedic injuries. All right, so musculoskeletal injuries are the most common reasons why patients seek medical attention. We get called for a lot of falls, sprains, strains, fractures. We're always called to these. This happens quite often. Easily identified because of associated pain, swelling, deformity. This is rarely fatal, but often result in a disability. So do not focus solely on the injury without first determining that there is no life-threatening injuries that exist. Never forget to assess hemorrhage, airway, breathing, circulation, stability, exposure. So AMP review. Let me get my highlighter back out. Okay. So bones are remember, bones form that framework, musculoskeletal system, right? One of our many body systems that we have in place. One of the 11 that we do have. Bones form a framework that gives the human body its shape and allows it to maintain an erect posture. It also protects the more fragile organs and structures beneath them, right? So it protects the abdominal cavity, thoracic cavity, those as well. Cranium, as we go through. So movement is created when a muscle contracts and the force generated by the muscle is transferred to a bone on the opposite side of the joint from the muscle. Another important function of the musculoskeletal system is the process of generating blood cells, right? So in the bones, we have what? What's inside of our bones?
Bone marrow?
Yeah, the bone marrow. And in that bone marrow, it starts that process of generating new blood cells. Blood cells help transport nutrients, oxygen, all that kind of stuff, right? The red blood cells, the white blood, all the different blood cells are being generated there. So very important part. So muscles, which are composed of specialized cells that contract when stimulated to exert a force on the part of the body. There are three types of muscles: cardiac, skeletal, and smooth. Right? So cardiac muscles are only found where? I'm going to circle this for you, but in the heart. That is it. Can cardiac muscle rejuvenate? Can it grow back? Can it heal?
No.
No, not at all. So once it dies, it dies. So when you hear the term time is muscle, when it comes to heart conditions, time truly is muscle, right? If it dies, it cannot rejuvenate, which is why we need to make sure we oxygenate, we vasodilate. That's a cardiac lecture, right? We have our skeletal muscle, right? All through here, all through the entire body. Skeletal muscles are all there. Then we have our smooth muscles that line what? What are our smooth muscles line?
Or lungs?
Yep, the lungs, the bronchioles, right? All that stuff, all smooth muscle. Perfect. Intestines. Perfect. You guys are right on track. I like it. The airway, like Matt said. So muscle innervation. So skeletal muscle is innervated by somatic motor neurons. So the combination of muscle and the neurons that innervates it constitute a motor unit. So recruitment is to generate a more forceful contraction where more neurons need to signal more muscle cells to contract. So the musculoskeletal body blood supply, the skeletal muscle, which is supplied with arteries, veins, and nerves, blood supply as well in each upper extremity originates from the subclavian artery. In the lower extremity, the blood supply originates from the external iliac arteries. So where would the subclavian artery be located? In the clavicle area, yeah, exactly. So one of the points of where we do an IO in the humeral head, we'll go to the next slide here, okay? So when we do an IO, we go through here, okay? In here is the subclavian vein that runs directly, kind of like this, to the heart. It's a direct access line to the heart. It looks like a central line access, very close. That's why when we run cardiac arrest, the best location would be up into the head, located in the top of the humerus. So there are approximately 206 bones in the body, right? When would you have more than 206? Or can you have more than 206?
When one breaks,
I like it. That's actually a good one. So some people are born with bones inside the ear, and they're called Wormian bones. And that's when you would have more than 206. It's not common in everybody, but some people have extra bones in the ears. So divided into the axial skeleton and the appendicular skeleton. The axial skeleton comprises the bones of the central part or axis of the body. Appendicular skeleton is divided into the pectoral girdle, the pelvic girdle, and the bones of the upper and lower extremities. So the upper extremities are composed of the upper arm, elbow, and forearm. So you have the radius and ulna, which make up the forearm. So remember this here is the ulna is underneath, and the my goodness, the radius is more in line with the thumb. So if you turn your arm over, so your palms up, underneath here would be your ulna. If you turn it back over again towards the thumb, would be your radius, ulna radius bone. Right, then we get into the hand. So the hand contains 3 sets of bones. We have the wrist bone, the hand bone, and the finger bones. So we can break this down even more. So we have our carpals, and in our carpal, there are 8 little bones in here. Our radius and ulna, carpals, 8 bones. Then we have our metacarpals. This will be labeled as 1, 2, 3, 4, and 5. So metacarpal 1, metacarpal 2, metacarpal 3, metacarpal 4, metacarpal 5. That's how they're actually listed. In our thumb, we have 2 bones. In our fingers, we have 3. Okay, we have. So what are these called? What are the fingers called? What's the name? Phalanges, right? So to change that, we're going to call it a phalanx. So we have a proximal, which would be here, and a distal phalanx. Proximal, distal. Then we have the hands, or the fingers. We have the thumb. We have the index finger, which has a proximal, medial, and distal phalanx. And the same thing goes down through the middle finger, ring finger, and little finger here. Proximal, medial, distal. Right? So as you're documenting and you have an injury to the finger or the tip of the finger, the index finger, you'll say that you have a distal phalanx injury in your report rating. So we have carpals, metacarpal 1 through 5, proximal, medial, distal, and the thumb, proximal and distal only. Now in the thumb, there's a joint that sits right here. What is that joint called? Remember the joint in the hand? Something you put on a horse.
Saddle joint?
Saddle joint, exactly. So you only have two saddle joints in the body, and that's each side of the thumb. So the saddle joint kind of sits in here. What are these joints called? Where I'm highlighting now. What kind of joints are the knuckles? These with an S. Anybody? Thoughts? No response, I will say. Probably not. All right, so they're called synovial joints. So we have saddle joint here, right? We have synovial joints here that contain synovial fluid. All right. So the pelvis supports the body weight and protects the structures with the pelvis. Okay. So we have the iliac crest. Oh my goodness, why am I going backwards? All right. So we have the iliac crest, the ilium being the big area in here, the sacrum, coccyx is down here. The pubic symphysis is this area right there. If that is open, and we have a fracture that goes in both directions here, this is what they call an open book fracture. This is the book as it opens up, exposing the arteries and the veins to fracture, to severing. Right? We have the ischial tuberosity, which is the lower part of the pelvis down here. The ischium is located here. The acetabulum. And then obviously our inferior vena cava and descending aorta going down into the femoral arteries, supplying blood flow to the legs. So the pelvic girdle consists of three separate bones. We talked about the ischium, ilium, and pubis. These are fused together to form the dominant hip or the hip bone. So they'd be in the hip bone here. Everything fuses together to make that one, right? But as you can see, though, and keeping in mind that there is a lot of vasculature through the pelvic girdle, not to mention our bladder, our kidneys, right? Kidneys are up here as they come down through the ureters into the bladder, which is located down here, okay? So a lot of stuff is protected in this area with the pelvic girdle, so we can have a lot of potential injury. All right, go down to the legs. All right, so we have the hip, pelvic bone going into the femur, very strong. This is the thigh. We have the knee, patella being the kneecap here. The tibia, fibula down here, the shin bone. This is important for us to know because when we do IO access, this is called the tibial tuberosity that runs through here. And then on the side, this little spot right there, medial, is called a tibial plateau. That's going to be an IO location, right? We can also do one in the distal tibia right down in here for an IO access as well. This is the ankle. So, and we'll get into the foot here in a second. What kind of joint is this? The knee.
Hinge?
Yeah, hinge joint, exactly. What about the one up here? Going into the pelvis.
Ball and socket?
Ball and socket. So, when we have a patient that falls down, so fall down, go boom patient, okay? They hit the floor and they have a lot of pelvic pain all through here, okay? You'll have the leg will be shortened. You'll have it going this way here, and it'll have an either outward, it'll have an outward rotation. If you have shortening and outward rotation, 90% of the time with a patient that falls with hip pain, they'll have a femoral head fracture. So what will happen is that the fracture will run through here. That femoral head up top will be one that's fractured here. Same thing with splinting, no traction, just wrap the pelvis, usually reduces the pain. So the pubic bone are connected anterior and ligaments at the pubic symphysis. Lower extremities consist of the bones that are of the thigh, the leg, and the foot, where the lower leg consists of two bones, the tibia and fibula, and the fibula is an attachment point to the lateral ligaments of the knee joint. This serves as a lateral stabilizer of the knee, of the ankle joint, and it's also a distal articulation. So getting into the foot, same thing down here. We have the Achilles tendon out back. Here's the tibia. And in the ankle, there's 7 different bones within the ankle itself. This is called the tarsal, right? So the tarsals have 7 bones inside. The calcaneus being the heel bone back here. Then we have metatarsals, and it's the same thing as the metacarpals in the hand. We have 1 through 5. Then we go into our phalanges, which are our toes, and we have proximal and distal phalanges in the foot. Any questions on that at all? Now, you guys seeing what are you guys looking at now for a screen? You guys looking at the foot right now?
Yes.
Okay. My computer screen, my separate screen, is actually still showing the hand. So I want to make sure you guys are still on the same page as me. Everything else is running slow on my side. All right. So you guys are seeing the foot and all the bones and everything else. Perfect. All right. So joints are formed whenever 2 bones come in contact. Right. So for the skull, we have sutures, right? Sagittal sutures, things like that, where there's no motion. A shoulder joint, or again, same thing, ball and socket up here, all right, is where you have circular motion. Shoulder joint, where you can move the shoulder, right? We have the sacroiliac joints, which run in the pelvis, located here, and the sternoclavicle joint as well, which is minimal motion. So things that have circular motions, those are your ball and sockets, okay? Where your hinge motions, like elbow and knee, would be the hinge joints. And then obviously we talked about the saddle joint and synovial joints in the hands. So motions that a joint may allow would be flexion, extension, abduction, adduction. So remember, flexion being flexing towards the body, extension being away, right? Abduction is taking your legs and kind of like spreading them apart, moving your arms away. Where adduction means adding to the body. Rotation, circumduction, pronation, supination. So pronation would be palms down, supination, palms up. Think about holding a bowl of soup. You might remember that as well. So bone classifications are based on their shapes. So we have long bones, which are longer than they are wider. Short bones, which are nearly as wide as they are long. Flat bones, which are thin, broad bones. Irregular bones that have a complex shape. And sesamoid bones, or round bones, are generally found in tendons. So let's go a little more into the bone articulature. So the bone architecture of this here would be divided into the diaphysis, epiphysis, and metaphysis. So we talked about the bones a little bit more in detail before. So this area where 2 bones come in contact to form a joint is covered by a thin layer of articular cartilage. For portions of the bone that is not covered by articular cartilage is covered with a periosteum. So the inner portion of the long bone becomes, or long bone, blood comes from the nutrient artery in the bone itself. So we have that bone marrow inside here, right? This is where our red marrow and everything else, nutrients and whatnot, are creating those blood vessels we were talking about. And the periosteum being that layer of the bone. Important stuff for us to know here for the long bones, right? So this was a femur, so not femur, the tibia, right? The part of the diaphysis is the tibial tuberosity, which literally runs up and down. And then if you go, like I said, if you go inside 2 fingers over into that flat spot here we call the tibial plateau, and that's an important landmark for us for IO access. All right. So understanding the layout of these bones and how they work will help us determine where we're going to be doing different access points as well. As far as treating the fracture, all right, if it's at the hinge itself by the knee and it's bent, we have to use board splints to be able to stabilize the knee in a bent position. If it's straight, we can utilize board splints, we can utilize vacuum splints, whatever it may be, keeping that bone stabilized. Remember to also check CSMs before and after. Tendons, ligaments, and cartilage. Remember that tendons connect muscle to bone, right? And ligaments connect bone to bone. The tendons cross joints, creating a pulling force between two bones when a muscle contracts. Ligaments connect that bone to bone itself, and cartilage consists of fibers and collagen embedded within a gelatinous substance. So where will we find cartilage within the body? Give me a couple locations where we find that cartilage.
Your chest.
Yep. So between the ribs, right? The cartilaginous areas between the ribs. Where else? The nose, ears, right? We have cartilage in those, right? Right. So let's talk about age-associated change. So bone density decreases after the age of 35, which leads to a loss of height and produces changes in facial structure. In women, the decrease in bone density accelerates once menopause is reached. So a significant decrease in bone density, osteoporosis, is associated with a higher risk of fracture. So aging of muscles, cartilage, and other connective tissues may lead to degeneration of joints and disc herniation. So as you can see in the photos here, this being the younger, below 35, as we get older, we start losing that bone density, which makes us more prone to fractures as we get older. That's why we deal with the elderly, and if they fall down, something that we may fall down and go, yeah, we're okay, right? More embarrassed to kind of lay there for a few minutes. When they're down, they have a higher chance of obtaining a fracture. If a patient is in pain, whether you notice a fracture, decap BTLS or not, if it's in pain, splint it, because it potentially could be a fracture, right? So with the pathophysiology, so injuries that may result from both blunt and penetrating trauma. Sports injuries account for a significant number of musculoskeletal injuries, right? So among children, intentional trauma or abuse is a common cause of fractures and musculoskeletal injuries. Pathologic fractures occur when a medical condition causes the bone to become abnormally weak. Give me some medical conditions that would cause this. If you guys are typing, I can't see that anymore. My separate screen is completely like lost its touch, I think. So you're gonna have to unmute for now until I can get this part reset, because there's nothing. So what other things would you have that would other kind of conditions would indicate that? All right, cool. I just kind of reset that really quick. All right, so osteogenesis, osteoporosis, yeah, perfect. So I'm starting to see those come through now. What just happened? Hold on a second, guys. My computer just went crazy again. Hoping this will kick in now so I can actually see everything. All right. That's weird. Where'd it go? All right. Can you guys still hear me okay?
Yes.
All right. That was weird. Everything just kind of like reset on my computer. But yet I was still recording. I'm not sure what just happened there. All right. We'll go with it. So apparently the chat box is moving ever so slowly that I'm getting some of your stuff so late. Like ball and socket from Justin, I just got that now. So that's kind of weird that's happening. So I'm going to try my best to see if I can make this work. All right. So sports injuries, things like that for musculoskeletal injuries. The mechanism of injury, obviously significant force is required to cause fractures and dislocations as well. So the force may be applied to limb by direct blow, indirect blow, twisting forces, or high energy injuries. So direct or indirect forces that may happen. Twisting, I've seen that a couple of times. People, whether it be wrestling or things like that, to diving injuries where they're diving underwater or twisting forces that can cause significant spinal injuries in a twisting motion. So a lot of those potentials are out there as well. So again, look at the mechanism of injury, and you have a potential to see that happening. So a direct blow fracture to the bone at the point of impact or high velocity injury typically shatters the bone and causes extensive soft tissue damage. Excuse me. So an impalement injury, which is similar to that seen in a low velocity penetrating injury. If we have that, we want to make sure we stabilize that object to protect the soft tissues from further injury itself. And an indirect injury, which occurs when force is applied to one region but causes an injury to another. So forces may be transmitted along the entire length of a bone or through several bones in a series. So you want to identify the point of contact in the MOI to decrease the chance of overlooking any associated symptoms or injuries itself. So twisting forces are a common cause of musculoskeletal injury. And some injuries are commonly encountered together because of the way the causative forces are transmitted. So like we talked about in motor vehicle crashes with knees hitting the dashboard, that transmission of energy to the pelvis. So if you notice they hit, don't just be stuck on that patella or knee injury. Is there potential for a pelvic fracture, right? If we have someone that goes up and over through a windshield, think of the projectile path. We're going to have head trauma, compression against the windshield, potentially causing cervical trauma to the chest hitting the steering wheel as well, causing potential for pneumothorax, rib fractures. So look at that pattern. If you see the injury pattern that's there, you want to make sure you look into that more in depth and say, if I see this, does my injury pattern show this? And if you can't see it, it doesn't mean that it's not actually fractured or something actually going on at that point in time. So fractures occur when the magnitude of force is applied to a bone, which overcomes the strength of the bone itself. Okay, the femur is a very strong bone, so it takes a lot to actually have that type of fracture. Kind of like the sternum. The sternum is still a very strong bone. So to have something break your sternum or fracture the sternum itself, it takes a lot of force. What about your clavicle? Does the clavicle take a lot of force to break? So yeah, like 6 pounds. It doesn't take much. It's very, very easily fractured bone. We see that in like bicycle accidents, sports injuries, things like that as well. Yes, they are pretty good pictures. So there's two types of fracture, one being open, one being closed. Obviously, pretty self-explanatory. Here's your open fracture, then your closed fracture located right here at the ankle. Either way, one of these, major bleeding, control it, okay? If there's no major bleeding, keep it the way it is and check for pulses. If you do not feel a pulse, okay, there are no pulses distal to the injury, then we have to do manual realignment to get pulses back. If there is a pulse, like on this foot here on the right hand side, splint as it is, checking CSMs pre and post. Angulation is when a bone is misaligned as a result of the injury, and the angle has formed between the fractured fragments. A non-displaced fracture is a simple crack in the bone. A displaced fracture is when the two bone ends of the fracture are separated, at least in one plane. I wish they had some pictures of that, x-rays. It'd be pretty cool to see those. So terms to describe the types of fractures. So the first one is called a transverse fracture, as you can see here. Then we have an oblique fracture, which is here, goes from one up this point down. Then we have our spiral fracture, which kind of goes around, kind of circles back through and around again. Right down here we have a commuted fracture, as you can see, located there. Right. Then we have our green stick fracture as well. Right. This is spinal here, compression. They can be incomplete, pathologic as well, or epithelial fracture as well. When would we most likely see green stick?
And younger kids.
Yeah, the younger children, right? Exactly. So signs and symptoms obviously is your decap BTLS. Deformity, shortening. So this right here, as you can see, you see how the foot is shorter and rotated outward? So the length is different here. And this has an outward rotation, right? There could be a fracture potentially there. I see some deformity. But if that was straight in line, okay, an outward rotation and shortening that way, I would think a pelvic fracture up in here, right? Swelling and bruising, so you can see a lot of the ecchymosis discoloration. This is potential for an ankle fracture. Bruising, ecchymosis, tenderness, pain, guarding, crepitus, or a grating sensation over the bone ends kind of going back and forth over the top, or false motion occurs at a point of limb where there is no joints, right? So as you're palpating and feeling this through here, try to see if you can feel any bone fragments underneath. This is an open fracture, as you can see, a locked joint, which is difficult and painful to move. So the joint is locked, which is located there, right? So in an open fracture, the exposed bone ends may be visible in the wound itself. So this one here, obviously a lot of packing of gauze to control the bleeding, wrapping it up, and then splinting in place, right? If there is no pulses, as you check pedo pulses down here, if there isn't any, we might have to realign to get pulses back. Dislocations is as easy as it is sometimes to relocate these fingers and get the synovial joint back in place. We do not relocate or dislocations unless there are no pulses. If it's dislocated with a pulse, we leave it in place and let the hospital take care of it. So the bone is totally displaced from the joint, so basically pops out. Some people, all right, Matt, I heard you. So some people have frequent dislocations as well. So kind of play that by ear. Ask them, has this happened before? We get a lot for hip dislocations. Those are very, very, very painful, right? So if you have a patient with a hip dislocation, call for a medic for pain management before you move them. It's going to hurt bad, right? So this may spontaneously undergo reduction as well. So this occurs when body parts move beyond its normal range of motion. So partial dislocation of a joint is known as a subluxation as well. So signs and symptoms would be marked deformity, swelling, pain that is aggravated by an attempt at movement, tenderness on palpation, virtually complete loss of normal joint motion or locked joint, numbness or impaired circulation to limb or digit, which is considered an urgent injury because of its potential to cause neurovascular compromise distal to the injury site. So always assess the patient's neurovascular status distal to the site of dislocation. We already covered that, right? We got to make sure we're taking a look at that distal location, making sure we do have pulses present. IV therapy, cardiac monitoring, right? That helps us monitor that shock, right? I know it's not cardiac in nature, but it can help us give a true time of heart rate. I don't always trust pulse oximetry heart rates, but P-wave, QRS, and T-wave in an EKG, that's accurate. That's the now, what we're seeing at this point in time. All right, so sprains. So ligaments that are stretched or torn. Sprains and strains hurt more than an actual fracture itself. They also take a lot longer to heal. So usually a result of a sudden movement of a joint beyond its normal range of motion. So rolling your ankle, things like that. Signs and symptoms would be point tenderness, swelling, and ecchymosis, pain, instability, and they rarely involve any kind of deformity, but that significant pain. So like I said, sprains and strains can take quite some time to heal. So strains are an injury to a muscle and or tendon that results from a violent muscle contraction or from excessive stretching, like overstretching an area. Only minor swelling may be noted at the site of the injury, but it still can be very painful. An Achilles tendon rupture usually occurs in athletes older than 30 years old, 30 years, involved in a start and stop type sport. So we see those in like football, basketball, things like that. So the most immediate indication are pain from the heel to the calf. So what's happening with an Achilles tendon or torn Achilles tendon, remember that's under a lot of pressure. So if it snaps down low, it rolls up into a ball into your calf. So as you're palpating, you're going to feel a ball, almost like a Charlie horse, a cramp, but it's going to be a solid ball in your calf because that Achilles tendon rolled right up into your calf muscle itself. Most immediate indication for that are pain, So acute management includes RICE, so rest, ice, compression, elevation, and pain control. These are significant pain, so Tylenol and Motrin may not be the best of choice. However, if you're running at the A level in New Hampshire and you don't have the ability to give Toradol or something else for pain, start with that first. But still call for ALS paramedic level care to get the higher pain management. So Rosa, I'm trying to read yours. When did you send that? I do apologize.
A couple seconds ago.
Okay. So that's when you actually had an Achilles tendon tear or roll up in your calf?
Yeah, and then I had one over in my like on my own on my elbow as well.
Oof. And that's painful. And it doesn't just go away. And that's usually a surgical procedure to put that stuff back. It's surgical to put it back anyways.
Yeah, for both of them it was immediate surgery right away. But yeah, you could see it's literally the size of a baseball.
Yep. Because it rolls up into that calf muscle. So again, splinting, control swelling, ice, elevation, pain management. Did they give you anything, Rosa, for pain right off the bat when you had that?
Yeah.
Yeah. Pain management is key for those. So amputations, that's bad, right? So this is a separation of a limb or other body part from the remainder of the body. So hemorrhage can be severe and life-threatening. A lot of times with this, you'll obviously tourniquets placed, pain management. Obviously with these patients here, honestly, the best pain management is ketamine for these patients. That's my own opinion on that, because we don't have the potential of reducing that blood pressure. So fentanyl and ketamine together work really well for amputations. I've seen significant injuries like this before, boating accidents. This one here kind of looks like almost looking at the tearing, the avulsions that you're seeing here, or they get caught in a propeller. So I've seen that before a couple times in the lakes, but again, it's tourniqueting and transporting the limb on ice, obviously wrap first prior to. So patient assessment. Let's see. Do not become distracted, obviously, by visual impressive injuries. Right. Take a look at the whole picture. Assess your patient. Look at the MOI. Maintain a high index of suspicion for associated injuries. If you suspect that your injury pattern should be there, it probably is. Other priorities will be identifying the injuries, prevent further harm, support the injuries. Obviously, remember the golden hour. Pain medication if necessary. If it's life-threatening, stabilize it, splint it, tourniquet it. Right, non-life-threatening injuries can wait until your life-threatening injuries are taken care of. Remember the golden hour? You have an hour to get the patient to a center that can handle this patient. Any suspected open fracture or vascular injury is considered a medical emergency. It needs to be transported appropriately. Identify any critical injuries using the musculoskeletal injury grading system shown on table 33-2 in your books. So as far as seeing size up goes, look for mechanisms of injury, hazards, evaluate, be alert for both primary and secondary injuries. If it is a traumatic event, make sure you don't put yourself in a situation where you're going to be injured as well. Focus on the patient's mental status, the XABCDEs and priority. Continue history taking, sample, PQRST, pertinent negative, associated symptoms, right? And then the secondary assessment as well. In case of non-life-threatening injuries, conditions do exist, we can start treating those at that point in time. Identify the injuries to prevent any further damage, right? So obviously in your secondary, if they have a tib-fib fracture, you can splint those, ankle fractures, elbows, humerus, radial on the things like that. Evaluate the patient's level of consciousness and orientation. Remember, things can change quickly with traumatic patients. Check responsiveness utilizing the AVPU scale. Minister oxygen is needed. Remember, as needed, every patient needs oxygen via a non-breathing mask. Again, Nasal cannulas, we're talking real world. Not every patient requires a non-rebreather. If they're bleeding out, then yes, getting more oxygen is not a bad thing. But they have a simple fracture. We don't need to start loading these patients with non-rebreather masks. It's a simple fracture, right? They may not even need O2 at all. So play it as a clinician. Look at your patient. Do they need it? Do the indications, the mechanism of injury, and what you see in front of you based on your evaluation require O2 administration? If a spinal injury is suspected, obviously take appropriate cautions and address any hemorrhage first. You can try to fix the airway, but if they bleed out, they're dead anyways. So control the bleeding. Assess circulation, treat for shock, right? Patient lying down supine or head elevated a little ways to protect the airway, right? Blankets, heat packs, keep the patient warm, oxygen is needed. Sterile dressings to cover the wounds of the bone. Obtain your sample history, OPQ or STI. Remember what was done prior to you getting there. Any intervention is done prior. Was it splinted out in the woods? Was it a mild carryout? What has been done? Has any pain meds been given prior to your arrival? Looking at our secondary assessment, we're going to treat the patient as having experienced a significant trauma when 2 or more extremities are injured. So if they have bilateral arm fractures, arm and an ankle fracture, we're going to consider this a significant trauma, something that broke 2 different bones, right? Examinations would be start with a full body exam, head to toe. You need to touch everything, right? We're going to identify hidden and potentially threatening injuries by doing our head to toe assessment. When examining a stable patient with an isolated injury, obtain a baseline set of vitals. We got to look for that trending that's there. Okay. Note DCAP BTLS, and remember to cover the 6 P's of musculoskeletal assessment. That's going to be pain, paralysis, pulselessness, paresthesia, pallor, and pressure, and evaluate circulation, motor function, and abnormal sensations, or CSM checks. Consider distracting injuries. Assess the entire zone of the injury itself. Look at the entire injury. And always evaluate the joint above and below the site of the injury itself. Make sure there were no other damage or any kind of radiated type pain. We're doing inspect for DCAP BTLS, deformities, skin changes, swelling, any kind of muscle spasms, abnormal limb positioning, increased or decreased range of motion, any kind of color changes in the area, any significant bleeding, whether it be internal or external. Then we're going to palpate for tenderness. This may be the only significant sign of underlying musculoskeletal injury is you palpating and they have pain in that area, right? Palpate above and below the injury site. Don't actually push on the site itself. Identify regions of point tenderness and reassess the tender areas afterwards. Did my procedures that I have done, the treatments, help it or make it worse? So reassess it, reassess pulses, reassess CSMs, right? So palpation of the pelvis, apply pressure over the pubis symphysis to evaluate the tenderness and crepitus. Remember that we go in, apply pressure, and we rotate down. We do not rock a pelvis, right? The pelvic iliac wings toward the midline and posteriorly. Do not repeatedly examine the pelvis if instability is found. Don't keep going back to it and touching it. If it's broken, it's broken. Don't keep going back there to say, oh, maybe it healed itself. It hasn't. Examine the cervical spine, shoulder, right down through from cervical to coccyx, and feel right down the entire spine, looking for any kind of fractures, step-offs, things like that. We're going to look at neurovascular status, checking and assessing every 5 to 10 minutes. So setting your cardiac monitor for 5-minute intervals. Always recheck before and after splinting as well. Remember the CSM checks. So failure to restore circulation can lead to death of the limb itself. So again, if it's not receiving circulation, get on the phone with med control. You may have to realign that joint to get pulses back. Again, don't wait unseen. Start transporting to the hospital. If the assess neurovascular status, follow the skill steps on 33-1 and get your vital signs. Right? But you're just checking CSMs. As part of your reassessment, the primary assessment should be performed every 5 minutes for the unstable, 15 for stable patient. Interventions should assess overall conditions, stabilize ABCs, and control serious bleeding before treating the injured area. We're going to secure critically injured patients to a longboard and stabilize the spine, pelvis, and extremities. Remember that we talked about longboard stabilization. I get it, right? In New Hampshire, in Maine, right? We're not using backboards for stabilization, only for extrication now. But at the National Registry level, backboards are still part of the exam. All right? Everybody get that? So you're taking your National Registry exam and it talks about spinal immobilizing utilizing a backboard. Yes, you do. Because the national level has not taken it away. It's a state protocol. Right? Everybody got that, right? Okay.
Yep.
But make sure we clarify that because a lot of you have been working in EMS for a while now and have seen the changeover and know what our current protocols are. To report problems with ABCs, open fractures, and compromised circulation, right, before and or after splinting. Note what they are. In your documentation, give complete descriptions of the injuries and the MOIs associated with them. Right? Don't just say the patient has an arm fracture. Let's say we use femur for example. So patient has a femur fracture. Okay, is it open or closed? Is it mid-shaft, proximal, or distal? Did you use a traction splint or a board splint? Were the CSMs present before and after? What was the pain scale before and after splinting? All that information needs to be in your documentation, not just put a traction splint on. Okay. Why? Well, they had a mid-shaft femur fracture. Was it open or closed? Well, it was open. Then why did we use a traction splint? Right? We only use them for closed mid-shafts. So when the abnormality is identified, document specific deficit. Do they have good sensation but no motor function? Were pulses weak? Were they thready down in the foot? Again, document in detail of what you're seeing, what you're palpating, what you're doing. As far as emergency medical care goes, first steps of primary, obviously stabilizing the patient's ABCs if needed, rapid body exam, or focus on a specific injury. Always take standard precautions. Be alert for signs and symptoms of internal bleeding. Consider administering nitrous oxide for pain relief, as indicated by local protocol. In New Hampshire, at the AEMT level, it is within your scope of practice if your service carries nitrous oxide to administer it for orthopedic injuries. However, if they have abdominal pain from traumatic injury, we have to withhold nitrous because we do not. It is contraindicated for anything with the abdomen. The last thing you want is to put free-floating gas into the abdomen because the hollow organ is ruptured. Not that we don't want to put those kind of gases in there. Consider administering nitrous oxide and follow the skill drill 33-2 when caring for patients with musculoskeletal injuries. For a volume deficit due to musculoskeletal injuries, remember that fracture may lead to significant blood loss from damaged blood vessels within the bone. So we want to administer IV therapy to prevent the development of hypotension and an unstable condition. So we can start fluids. We want to maintain blood pressure and perfusion at a 20 ml per kilogram bolus as we administer these fluids to the patient. All right. So I'm going to give you guys a scenario here, and I need you guys to come up with how much fluid you're going to administer to the patient. So if I said to you the patient weighed 200 pounds, we'll keep it simple. How much fluid do you give? 200 pounds, based on the 20 ml per kilogram increment. £200.
1,118.
Nope, that's not. So 200 divided by 2. So 200 divided by 2 is 100. Minus 10 is 90. 90 times 20 is 1,800. Right? So you got to divide by 2, take off 10%, or if you want to use a calculator, it's 2.2. So 200 divided by 2.2 times 20 will give you your number based on the 20 ml per kilo. Now, if you look at local protocol, New Hampshire protocol, for adult patients, it's 30 mLs per kilo. At the national registry level, it's 20. So when you're tested on the national registry, you're doing 20 ml per kilo increments. Cold and heat applications. The cold packs are useful for treating patients during the initial 48 hours following an injury. Decreases pain and swelling, constricts blood vessels in the region, which is all good stuff, and decreases the release of inflammatory mediators. However, heat therapy should be avoided during the initial 40 to 72 hours following an injury. This may increase pain and swelling during that period. Right? So cold packs. You'll be amazed on how well PO Tylenol or Motrin, along with cold packs and splinting at the BLS level, will actually treat somebody's pain before you start getting into heavy hitters. That's why it's so important. Appropriate splinting, icing the injury, and here's 1,000 of Tylenol or 400 of Motrin. Right? That will reduce so much pain for certain patients, right? Before getting into heavy hitters and start giving them narcotics, right? I do not like giving patients narcotics unless I absolutely have to. I always try with lower stuff first. Maybe I'll go with Toradol because I have the ability to give that as a medic, but it is coming down to the advanced level here at some point in time. All right, so splinting. We'll get through the splinting section here, and we'll take a 10-minute break, and we'll come back. So unless the patient's life is in immediate danger, splint all fractures. Right, immediate danger, leave certain fractures alone. Dislocations and sprains as well before moving the patient. When no splinting materials are available, the patient's arm can be bound to the chest wall. An injured leg can be bound to the uninjured leg. So there are 3 major types of splints. There's traction, rigid, and formable. Right? So give me examples of a formable splint. Give me one example of one. Actually, give me 2. 2 examples of something that's formable. Yeah, SAM being one. And what's the other one you can utilize? Yeah, vacuum splint. Right? Traction is traction. Everybody knows what traction splints are. There's different types that are out there, 3 or 4 different types. Then we have rigid splints like our board splints. Perfect. So the best way to stabilize multiple fractures in a critical condition is to splint the axial skeleton utilizing a longboard and straps or alternative device. If you are utilizing the longboard as a stabilization tool for splinting, the patient can remain on the board if it's being used as a splinting device. If it's just being utilized for spinal mobilization, then they need to come off. Right? But if you're using it to split the legs or whatever it may be to hold it in place, that's perfectly fine. Just document why you're doing it. Cover all wounds with a dry sterile dressing before splinting and assess and record the patient's neurovascular status, distal to any injury site. Do not move the patient before splinting an extremity unless there's immediate hazard to the patient or yourself. For fractures, the splint should immobilize the bone ends and the 2 adjacent joints. For dislocations, the splint must be extended along the entire length of the bone. Excuse me. Above the entire length of the bone and below the dislocated joint. You also want to make sure you pad all rigid splints as well. Manually support the injured site with hands placed above and below the injury joint, below the injury on the joint itself, or above and below the joint if it's a joint injury. If a long bone fracture is severely angulated and there is no pulse present to the extremity, gently apply longitudinal traction. Do not attempt to straighten fractures involving joints without obtaining medical direction first. Call them first and have them walk you through it. If the patient reports severe pain or is resistant to movement, discontinue applying traction and splint the joint or the bone in the position of deformity. Avoid covering the fingers and toes with a splint, and apply cold packs and elevate the splint limb to minimize swelling. Make sure you stabilize all suspected spinal injuries in a neutral inline position on a longboard. Remember, this is natural registry. If the patient has signs of shock or hypoperfusion, align the limb in the normal anatomic position and provide transport. When in doubt, splint a patient. If there's pain, splint it. Some hazards associated with improper application of splints would be compression of the nerves, tissue, and blood vessels, delay in transport, the patient with life-threatening injury, reduction of a distal circulation, aggravation of the injury site or the injury itself, and injuries to the tissue, nerves, and blood vessels or muscles due to excessive movement of the bone or joints. As far as traction splints go, the most effective way to realign a fracture of the shaft of a long bone. With this, prevent the bone from bone ends overriding due to opposed muscle contraction. Remember, this is only for mid-shaft closed fractures we're using traction splints on. Potentially reduces pain, reduces blood loss, excessive traction can be harmful, so you only pull enough till they start feeling relief. Do not attempt to reduce the fracture or force the bone fragments back into alignment. Pull enough until you get relief from the splint itself. That's where we stop from there. The goal of inline traction is to stabilize the fracture fragments, prevent excessive movement, and align the limbs sufficiently to allow it to be placed in a splint. Avoid potential neurological or neurovascular compromise and use the least amount of force necessary, as you can see here. So if it's a mid-shaft femur, as you can see right there, right, we're going to bring it back in line. So we're going to be going medial, or what they call adduction, adding back to the body, and we're going to pull tension in that direction. Once you are assigned to the foot, you are pulling that traction here, right? At that point in time, you are married to this area until the traction splint is applied, and we can move forward. Do not use traction splints with extremities, upper extremity injuries, injuries close to involving the knee, injuries to the pelvis, or partial amputations or avulsions with bone separation. Lower leg, foot, or ankle injuries as well. This is really, it's only used for mid-shaft femur fractures that are closed. There are different types of splits are out there. There's hair traction splint, which is the ones that we've been utilizing. The Sager splint goes into the crotch of the patient. And then there's also the tent pole style as well. I'm drawing a blank on the name of those for some reason. I'm sure I'll come to me here in a minute. And then rigid splints, which are made from firm material that are applied to these sides of the front and back of the injury. And remember, it takes two providers to apply a rigid splint. So you must splint the limb in the position of deformity when deformity is severe, resistance or extreme pain is encountered when applying gentle traction to the femur of a shaft of the long bone. So we want to make sure we're applying padded board splints to each side of the limb. So on the board splints that we have, one side has padding, on the side it's like a hard board, padding towards the body. And most discolorations or dislocations, should be splinted as found. Right. So if it's a dislocated knee, as you can see in this photo here, we're using board splints. We're keeping it at a bent angle. So you take triangular bandages, as you guys probably already know this here. We go around these two locations here, and then down high and low to kind of hold it together. And we also pad underneath so that way there the knee can remain bent. As far as pneumatic splints go, used for stabilizing fractures involving the lower leg or forearm, not effective for angulated fractures or fractures that involve a joint. Air splints are most commonly used. There are different sizes, shapes. They always inflate after applying them. It kind of holds things in place. Helps control bleeding as well as reducing swelling. It should not be used in any kind of open fracture with any sharp bone ends that are exposed. So if you have open fractures like that, board splints. All open wounds must be covered with a dressing before applying these splints to these splints as well. Overinflation can occur as well when applied with in a cold area. The patient is simply moved into a warm area as well. Remember that patients are outside and they're cold. The swelling is not going to be as severe. When you get in the back of the ambulance, you got the heat going, everything starts to swell like a balloon. So you may have to reassess your splints and loosen them up a little bit so we don't block off all circulation. And carefully monitor the splint and let the air out of the splint if it becomes overinflated. Pneumatic anti-shock garments. Again, we're not using these anymore. Justin's going to bring one. Awesome. That's not a bit too bad of a crash. So with the mass trousers, the PASGs, Justin said he'd bring one down for Sunday's class. You guys can see what they look like. I don't have them. The states we work in do not use them anymore. So we don't really test them at all. They're also not going to be on any kind of your national registry testing, but it might be in your written test, but not your practical. So do not use the following conditions: pregnancy, pulmonary edema, acute heart failure, penetrating chest injuries, groin injuries, major head injuries. Because what you're doing is you're applying significant pressure to push the blood into the core. The last thing we want is to push more pressure into the brain. So inflate all compartments utilizing the device to stabilize the possible pelvic fracture. And once it's applied, we do not remove them in the field. They report patient's blood pressure at the time you applied the PSG and the results afterwards. Formable splints like vacuum, pillow, sling and swab, pelvic binders, SAM splints. These are all different ones we can utilize for formable splints. So you guys should be pretty good with those. And then pelvic binders. So this is a SAM pelvic binder that you see here. So we do have those in our trucks where I work. So we'll be able to take some of those out and play with those as well. Should be light, made of a soft material, easily applied by one person. Something very simple to use that. KEDs also work a little bit more to do with those, usually 3 different straps and everything else. But buddy splinting is used to splint injuries involving fingers and toes. So we tape the injured digit to another uninjured one. So you can tape, if you have a fractured pointer finger, you can tape it to the middle finger using that as a splint. All right. So we're going to take 10 minutes. Give you guys a little break here. We'll come back at 8:40, and we'll finish up. We're about more than halfway through. So we should be done by 9:30-ish. So let's take 10 minutes, come back at 8:40.
This conference will now be recorded.
All right, so as far as transportation goes, a patient with a pulseless limb or possible compartment syndrome must be given high priority, right? The compartment syndrome, obviously, with a lot of toxins or anything else, could potentially release crush injury, compartment syndrome, things like that. Pulseless limb, we don't have much time before that limb becomes completely useless and has to be amputated off due to lack of blood flow. So getting these patients to a hospital where they can either relocate through x-ray, things like that, to kind of help get that back in line is more chance of a patient losing a limb. So we got to make sure we get these patients to the hospital as soon as possible. So if treatment is more than an hour away, a patient with a pulseless limb should be transported by helicopter or immediate ground transportation to a facility, to a trauma center that can handle that. If circulation in your limb is impaired, consult medical direction. They might be able to kind of talk you through relocating that joint or bone to get pulses back. So as far as musculoskeletal injuries, they can lead to numerous complications, obviously often related to strength and the force caused by the injury, injury location, overall health. Obviously, infection, long-term disability, and pain. So infection, prevent infection by following open fractures, by brushing away any debris or the skin or surrounding the open fracture before applying a dressing. Long-term disability is one of the most devastating consequences with that, and what it's going to take through rehab and reconstructions, and depending on what it needs to be done. So honestly, analgesia during transport is what's really needed. They need that pain management, the heavier hitters potentially for that, any kind of pain management. Something else to mention with this as well, obviously with infection, and I'm very glad that Maine has jumped on board with this, is open fractures. Now the paramedics are now carrying ceftriaxone in their ambulances now to administer for open fractures, which is phenomenal. When we start that antibiotic sooner than later, it's done through an IV drip, usually doing over about 10 minutes or so with that. So if you have an open fracture, calling for ALS is not a bad thing for the main stuff. New Hampshire depends. Some medics do carry it, but it's more for the expanded scope. And it's actually down to the advanced EMT level for open fractures in New Hampshire, but it has to be part of the X protocol. Peripheral nerve and vascular injuries, also when blood vessels are damaged following a neuromuscular injury, devascularization can occur. Vascularization can occur. Displaced fracture fragments also may lacerate, impaled different nerve endings as well. So the neurovascular injuries are likely to occur following a joint dislocation. So it's important to assess and reassess pulses, control bleeding, and maintain adequate intravascular volume. Making sure that we have good pulses, looking at skin color, skin temperature, distal pulses, things like that. Compartment syndrome is one of the most devastating consequences of a neuromuscular injury. The longer it persists, the greater chance for tissue necrosis and death. So external and external and internal factors can lead to development of compartment syndrome. So the open fractures may have a higher risk of compartment syndrome because they're typically associated with a higher energy type injury. Usually develops within 6 to 12 hours after the injury, characterized by severe pain localized to the involved compartment where that injury is located. So you'll have skin pallor that may be present or may be apparent, as well as paresthesias as well, and late signs of absence of distal pulses in the affected extremity. So that compartment, that swelling going on in that compartment itself, causing significant pressure, which would make it not have the distal pulses in that affected area. So you want to make sure you get these patients to the hospital as soon as possible. And sometimes patients may treat at home, again, the OPQRCI interventions, and then 6 to 12 hours later, they're calling 911 with that. Can you guys still hear me okay? Yes? All right, power's flickering where I am, so I may lose you guys. So I'll keep going as far as I can, but if we lose power, we'll reconvene in the next class if I end up losing connection. So with compartment syndrome management should include elevating the extremity to the heart level, placing ice packs over the extremity, and opening or loosening constrictive clothing and splint material, allowing it to expand. Administer oxygen and crystalloid solutions as needed, and consider administering nitrous oxide for pain management as allowed by local protocol, and provide immediate transport and frequent reassessment of the neurovascular status. So as you can see in this photo here, crush syndrome. So crush syndrome occurs when the extrication or release of an entrapped limb. So rhabdomyolysis is a tissue necrotic, leads to release of harmful products. So rhabdomyolysis doesn't necessarily just have to be from a crush. Even an elderly patient that's been on the ground for 6 hours can cause rhabdomyolysis. So after a muscle is compressed for 4 to 6 hours, the muscle cells begin to die, releasing their contents into localized vasculature. The treatment should always be performed with medical direction. Many steps should be taken before releasing the compressive force. So if you have a potential for rhabdomyolysis or crush injury, it may release a lot of the toxins. And one of the things that happens is the fact that potassium is not being pushed through the cells appropriately. So paramedic care is required for these types of patients. So we do want to consider administering a bolus of crystalloid solution. Do not apply a compressive device, but they may need something like calcium gluconate or sodium bicarb, calcium chloride, something that can help push some of that potassium out of the cells. Another thing they can utilize too is a significant abundance amount of albuterol, but again, we don't even carry as much as it's required, but it is within the protocol to administer 20 milligrams of albuterol inhaled to help push that potassium out of the cells, to help with that crush syndrome and that release. So the thromboembolic disease, or DVTs, includes DVTs and pulmonary embolus. This is a significant cause of death, and signs and symptoms of a DVT would be disproportionate swelling of an extremity, discomfort in an extremity that worsens with use, and warmth of the extremity as well. So when a DVT dislodges, it may become a pulmonary embolus, or can release even as far as going into the brain, causing a stroke. So as you can see here, here there's an embolus down here. As it travels up through, it can go lodge into the pulmonary artery, causing a pulmonary embolus. So signs and symptoms of a PE, I'll go to the next slide, would be sudden onset of dyspnea, pleuritic chest pain, tachypnea, tachycardia, multiple syncopal episodes, another one as well, failure, shock, and then they can go into cardiac arrest. So patients with a long bone or pelvic fracture are at risk for developing fat embolus syndrome as well. So treatment for fat embolus syndromes in the field is maintaining the airway, adequate oxygenation, intravascular volume, and rapid transport. They're going to need surgical intervention to remove these. As far as the clavicle and scapula go, the clavicle is one of the most commonly fractured bones. We talked about that already. Fractures in the clavicle occur most often in children when they fall with an outstretched hand. Could also occur with a crushing injury of the chest. So a patient will report pain on the shoulder, will usually hold the arm across the front of the body for that clavicle fracture. So young children often report pain as well through the arm and are unwilling to use any other parts of the limb injured. The swelling and point tenderness occur over the clavicle as well. So you'll be able to actually feel it, look at it, you can actually palpate. You can see the differences looking at the clavicles coming through this area. You have a patient stand straight up and you can see the differences where it's dropped down and potentially could be fractured. Because the clavicle is subcutaneous, the skin will occasionally tent over the fracture, may lead to neurovascular compromise. It can also protrude through the skin as well, very easily, with that sharp point that's there. Another common fracture as well, which is in the wrist, is called a Colles fracture, and that's when a patient falls down, they try to catch themselves, or they could actually deliver the force and fracture their clavicle, but they can also have a Colles fracture in the wrist as well with that. So just kind of keep note that if they fall down, the clavicle pain may be more significant, masking the pain of the wrist, or the Colles fracture of the wrist. So you may have a wrist fracture as well. The fractures of the scapula and shoulder blade are occur much less frequently because the bone is well protected by many large muscles in that area. So the result of a violent direct trauma to the back directly over the scapula could cause a fracture of this. And you can look at the ecchymosis located here that indicate that type of injury. They also injure the thoracic cage, lungs, and heart. So carefully assess the patient for pneumothorax, hemothorax, and rib fractures, listening to lung sounds. Abrasions, contusions, and significant swelling may also occur, and the patient may also limit use of one arm. So get a decent set of lung sounds, looking for that pneumothorax. Look at the decreased or absent lung sounds on that side. The joint between the lateral aspect of the clavicle and the acromion process of the scapula is called the acromial clavicular joint, or AC joint. This frequently separates during football and hockey when players fall and land on the point of the shoulder, driving the scapula away from the outer end of the clavicle. The dislocation is often called an AC separation. So the distal end of the clavicle will usually stick out when the patient will report pain on point tenderness over the AC joint itself. So you can see the location right there, where I circled. So fractures of the clavicle, scapula, and AC separations can be effectively splinted with a sling and swath, as you can see here. So be familiar with that type of splint. Dislocation of the shoulder is the same thing as well. So as you're looking at the shoulder here, you can kind of see the dislocation, looking at how it drops down farther. as well. Most commonly dislocated large joint in the body is the shoulder. So splint, humeral head is most commonly dislocated. So the humeral head will pop out in this direction here and kind of drop the shoulder in a downward angle. So patients will actually guard trying to protect it. So have them hold it and manually hold it in place. Check your CSMs before and after splinting. You can apply ice to the shoulder as well to kind of control some of that swelling. The humeral head will protrude anteriorly underneath the pectoralis major of the anterior chest wall. All right, so you'll kind of see it up in here. So again, stabilizing, as you can see. So I'm going to swap pillow underneath to replace whatever needs to happen, and then apply ice, cold packs to kind of reduce the swelling. Discoloration and dislocation of the shoulder disrupts supporting ligaments of the anterior aspect of the shoulder. So dislocation usually recurs because these ligaments often fail to heal properly. So once you've had one dislocated shoulder, it may pop out again. Some patients can reduce or set their own dislocated shoulders, so they're used to putting it back into place. The shoulder dislocates posteriorly instead of anteriorly about once in every 20 cases. I have only seen a couple that have dislocated posteriorly in the ER, but it hasn't been that many. The arm will often be locked in an abducted position. Adducted, so again, to the body, adding to the body, so it cannot be rotated around. So reducing the dislocation usually requires medical supervision for that. Fractures of the humerus may either occur approximately in the midshaft or distally at the elbow. So proximal humerus fractures from falls are common among older adults. You have that proximal fracture of the humerus up more towards the shoulder. So the midshaft fractures occur more often in young infants, young patients, not infants, usually a result of a high energy injury. So I've seen quite a few midshaft fractures as well in my time so far. So examine the extremity to reveal any significant swelling, ecchymosis, corrosion, instability of the region, and crepitus. So radial nerve may also be injured as well by the force of itself becoming entrapped. So the classic sign is that wrist drop. The wrist kind of just drops down. So we're going to stabilize, keeping it in a bent angle. If that is position of comfort, usually it is. And we're going to apply that board splint along the side here, that board splint, to kind of hold it in place. So this will require more of the swap going around to kind of hold that board in place, but the sling as well, keeping that elevated to prevent any more further damage. If we have an elbow injury, we can use a SAM splint, as you can see in this photo here, kind of wrapping down and around, or we can use double short board splints and kind of go around, keeping that joint immobilized. And then after this is placed, you can place the sling underneath it to kind of hold it in place, or place a pillow underneath on the stretcher underneath the arm of their body to kind of support it. Cold, pale hands or weak absent radial pulse or poor capillary reflow indicate blood vessels have been likely injured. So consult medical direction immediately, and if the pulseless and significantly deformed at the elbow, apply a gentle manual traction in line along the axis of the limb to decrease that deformity as well. We want to make sure we can try to find a way to get those, get that pulse flowing again, that blood flow moving to the extremity, so we don't lose it. So fractures of the forearm. So fractures of the shaft of the radius and ulna are common in people of all age groups, but are seen most often in children and older adults. So both bones break at the same time when injury is the result of a fall or an outstretched hand. So we're going to talk about Colles fractures here in a second. So you can see the deformity here. So there might be a fracture up here, and then I'll see the fracture down here as well. This is a Colles fracture. So a fracture of the distal radius going into the wrist, like I mentioned earlier, and a silver fork deformity, distinctive appearance in the patient's arm. So it kind of looks like a fork, the fracture located here. In children, this fracture may occur through a growth plate, and can give a long-term consequence, right? So that's the problem, is the growth plate being located down here. So if we have injuries or fractures that disturb the growth plate, this can cause long-term consequences where the bones can no longer grow appropriately, right? So there's growth plates located here, down here, basically in all the different joints is where you would find growth plates that allow also for the bones to grow. So to stabilize fractures of the forearm and wrist, use a padded board splint, air, vacuum, pillow splints, whatever you need to utilize for those. If the shaft of the bone is fractured, include an elbow joint in the splint as well. So a lot of this stuff here is pretty much review. So injuries to the wrist and hand must be confirmed by radiographs, x-rays. Dislocations are associated with fractures as well. So common wrist injuries is isolated non-displaced fracture of the carpal bone, especially in the scaphoid as well. Hand injuries vary widely, and some have potential serious consequences in the hands. All hand injuries must be elevated promptly by a physician, so do not attempt to pop or a dislocated finger joint back into place, right? Make sure you bring them to the hospital, have them do the x-rays first, so they can see how they need to put it back in place. Always take an amputated part as well to the hospital. Please do not soak the part in water or allow it to freeze. Again, so we're wrapping it up, putting it onto ice. Fractures of the pelvis, relatively uncommon injuries, but they do happen. Responsible for a significant number of deaths in blunt traumatic patients. We have those major arteries and veins that run down through the femoral, right? So death results from massive hemorrhage. So we have to be able to, we have to splint, we have to stabilize, right? And we have to make sure that we're calling for ALS care now that we do carry TXA for medics. So occur in secondary high injury trauma such as crush injuries, motorcycle crashes, falls, things like that, falls from significant heights. So a number of structures in the pelvis are at risk. Remember, we talked about the bladder, urethra, rectum, vagina, sacral nerve plexus, the veins within the pelvis, internal or external iliac arteries and arteries in the lumbar region, nerves in the lumbar and sacral regions, and the sciatic and femoral nerves as well. So a lot of these different injury patterns could happen if we have that pelvic fracture or fracture of the pelvis itself. That's why it's so important to make sure that we stabilize that. Treat with pain management, kind of help them become more comfortable. This is going to require surgical procedures as well. So nothing by mouth. Okay, so if you suspect that, no PO Tylenol or Motrin, no water, or they need to be NPO because they're going to be going into surgery as well. Maybe accompanied by life-threatening loss of blood. So if you have a patient with a potential pelvic fracture, vital signs every 5 minutes. Look for that trending. So often there are no visible signs of bleeding until severe blood loss has occurred. So we got to look for those changes. I remember I told you guys before about my motor vehicle crash rollover a couple months ago. And then Sean was on that call with me. And we saw that sustained heart rate. Nothing else was there. But my gut instinct and the assessment that I did, along with looking at trending and vital signs and not seeing any changes in heart rate after pain management, I knew that this kid had an internal bleed. There was something going on inside that pelvis. So I gave the TXA, like I said, it saved the kid's life. So you have to look at everything, what you see, what you're doing, projected patterns of how the patient was laying on the ground too, whatever it may be, and say, this all lines up with this type of fracture. More severe injuries may show profound shock, gross pelvic instability. The next one I have here is actually an X-ray, which is pretty cool. I'll show you the next slide. Bruising or lacerations, the perineum, scrotum, groin, suprapubic region, and flank. Hematuria is blood in the urine, blood coming from the meatus of the penis, vagina, or rectum. Lateral compression, pelvic ring disruptions result from impact of the side of the body. So the side that sustains the impact becomes internally rotated around the sacrum, often associated with injuries in other regions of the body. So looking at this picture here, you can kind of see that rotation where the patient fell. You can kind of see the rotation right in there. So you can see the fracture here. You can see it displaced in here. Right, you have that kind of rotation. That's going to cause the shortening of the leg going this direction here, and that will have an inward rotation as well of the foot. So this is a radiograph of the lateral compression fracture. So the anterior posterior compression pelvic ring disruptions may occur following a head-on MVC, motorcycle crash, fall, or pedestrian struck or head-on by a motor vehicle. So the force of impact compresses the pelvis in anterior and posterior direction, causing the pubic symphysis or posterior supporting ligaments to tear apart. The pelvis then separates or spreads apart, separates like a book. Mentioned the symphysis, pubic symphysis, and spreads apart. And this has potential for massive blood loss if not stabilized, which is why it's so important to get that splint on right away. The major forces applied to the pelvis and above or below. So I kind of mentioned everything we've been talking about so far before we go more into this slide. These patients still require cardiac monitoring and require at least a 4-lead and require IV therapy. Whether fluids are given or not, getting an IV in place, right? So we talk about this, we don't mention IV therapy, cardiac monitoring, but those are two key things on all these patient contacts. We need to make sure we get it. Oh, sorry, wrong button. So vertical shear, a major force applied to the pelvis from above and below. From landing, forces transmitted through the legs to the pelvis leads to complete displacement of one or both sides of the pelvis towards the head. Patient is likely to have significant shortening of limb on the affected side and risk for massive hemorrhage into the pelvis when we have that shearing potential of the femoral artery. So the straddle fracture occurs when a person falls or lands in the region of the perineum. This is seen as bilateral fractures of the inferior superior rami as well. Does not interfere with weight bearing, which carries a risk to associated complications. An open pelvic fracture is life-threatening. So patients with lacerations of the skin in the pelvic region, vagina, or rectum. This is very uncommon to see an open pelvic fracture, but can be there. This is usually caused by high velocity injury with subsequent massive hemorrhage. Even small amounts of blood found during vaginal or rectal exam should raise suspicion for that open fracture because it's leaking, as you can see here. So as we're palpating and testing for tenderness, see how we're pushing down. We come in on the iliac crest on both sides, right? So in, kind of downward, if I push down on the pelvis, look for any kind of deformities at all with the crepitus. With injuries to the bladder, urethra, or lower abdomen, tenderness and hematuria or blood at the urethral opening may be present. So we need to actually expose and take a look and see if we see any, right? If you notice any bleeding, we have to suspect there's internal bleeding in the pelvis. So treatment should be ABCs, spinal immobilization, IV access, at least one large bore catheter, and fluid management. And management involves reducing the amount of bleeding and decreasing the degree of instability. That's the biggest thing. So methods of stabilization, we can use the MASS trousers, again, National Registry. We're not going to be using those in the field for real world stuff. Once immobilized on a longboard, the patient should be transported rapidly to a trauma center. Now, I want to make this a mention as well. Actually, before that, though, IV fluids, cardiac monitoring, and avoid any kind of hypertension to kind of flood the pelvis even more and push out our cells. So to kind of make a mention of this, pelvic fractures. More femur fractures than anything else, I shouldn't say pelvis, but midshaft femurs. If you're calling for a helicopter, they can only handle up to a certain height patient when they're laying completely supine. So a lot of times the hair traction splint will not really work too well, but the Sager splint works a lot better for helicopter use because it doesn't stick out far above the foot. So again, plan what you're trying to do. If you have the Sager splint, those work a lot better than the hair, especially if you're going to be flying a patient, so they can fit in the back of the helicopter itself for flight. Dislocations of the hip obviously dislocates only after a significant injury for hip dislocations. But I'll show you one in the next slide here. So the femoral head is displaced posterior to lie in the muscles of the buttocks. So suspect hip dislocation of patients involved in MVC and have a contusion, laceration, or obvious fracture in the knee region. The femoral head rarely dislocates anteriorly, usually it's posterior. The legs are suddenly and forcibly spread wide apart and locked in this position here. So again, knee strikes. You can see the arrow coming down to the pelvis, pushing that posterior, going back out. So you may see like a foot drop in this as well. It also can be complicated by injury to the sciatic nerve. All right, so patients with posterior hip dislocations of the hip typically lie with their hip flex, as you can see here. The hip joint flexed and the thigh rotated inward in midline to the body over the top of the thigh. So they had a dislocation down here, and they're going to rotate inward. So we may have to splint. You can see the rotation as well in the foot down here. So that would be more towards that dislocated hip. So shortening, rotation, and in that flex position. So we're going to have to stabilize in position and comfort. Some of these symptom signs would be severe hip pain, strong resistance to the attempt to move the joint. Lateral posterior aspects of the hip region will be tender on palpation as you're palpating. And check for sciatic nerve injury and assess sensation, motor functions, in lower extremity. So again, CSMs. We have to make sure we're checking those, make sure we're actually getting good circulation and neurovascular status down to the lower extremity. So check for those. Do not attempt to reduce a dislocated hip. Okay, those usually go under X-ray first to kind of see where it's located. Please do not try to attempt to reduce those. Splint in the position of deformity, get the patient onto a board and get them out to the ambulance. So really, you want to make sure we support that effective limb with pillows and rolled blankets. So we want to make sure we pad around. Every ambulance should be carrying 6+ blankets, things like that in the back of the ambulance. So utilize what you have. We got to make sure we get that good stabilization. So fractures of the proximal femur, so common fractures, especially in the older adults, usually called hip fractures, the proximal side, rarely involve the hip joints. Usually the break goes through the neck of the femur. I mentioned that femoral neck or femoral head. So the trochanteric middle region, or across the proximal shaft of the femur, the subtrochanteric fracture. So this usually occurs most often in older patients, particularly patients with osteoporosis, and may be a result of a high energy injury in younger patients. So if you notice here with the injury, right, you see how they place them on the board and splinting. So the leg externally rotated and shorter than in the uninjured limb. So you can see the outward rotation here. And this is actually going to be shorter going up. And then you have that femoral head up here that's actually fractured. On occasion, pain is referred to the knee. So pain will actually refer down to knee pain for this if you happen to see it. These patients here should usually require analgesic medication as well. So assess the pelvis for any soft tissue injury and bandage appropriately, and obviously pulses and neurofunction and assessment. All patients may have significant blood loss. So oxygen, IV therapy, cardiac monitoring, vital signs every 5, and be alert for signs of shock. Almost done. So femoral shaft fractures can occur in any part of the shaft. So following a fracture, the quadricep muscles begin to spasm. So the muscle spasm often produces significant deformity of the limb itself. These are our femoral shafts. Usually the limb also shortens significantly. So fractures are occasionally open and fragments of the bone may protrude through the skin. The patients often experience significant blood loss, so cover any wound with a dry sterile dressing. If the foot or leg below the level of the fracture shows signs of impaired circulation, apply gentle longitudinal traction to the deformed limb in a line along the axis of the limb. So grabbing the foot, like we saw in the picture earlier, we're pulling back to that femoral shaft to kind of hopefully reduce that pain. All right, monitor for shock, full mobilization. and then place the extremity in the traction splint. Right. So get rid of this right here. We're not using the PASG, but traction splinting is the way to go. As far as knee injuries goes, there can be ligament, dislocated patella, or fracture. If it's a bent knee injury, we want to make sure we keep it bent. We use board splits on each side to support it, placing pillows underneath. Again, if we have a dislocated patella, we're not putting those back in. They are very easy to do, but it's not within our scope of practice to put those back in place. But it is very, very painful to be out. So Tylenol is not going to help this patient. They need something stronger than that. As far as dislocation of the knee, ligaments may be torn or damaged. So always check the distal circulation as well. The anterior posterior ligaments are commonly damaged with those. So direction of the dislocation refers to the position of the tibia and with respect to the femur. So the anterior posterior ligaments are commonly damaged. So the posterior dislocation as a direct blow of the knee forces the tibia to shift posteriorly. And then medial dislocations result in a direct blow to the lateral part of the leg. Right. So patients typically report their knee, and the knee they report that they kind of just gave out and kind of fell to the ground. So you can kind of see in this photo here, you can see it. So if your patient's wearing pants, obviously cut the pants off before you splint. Take a look at what you have, right? Make sure that you have good adequate pulses. A lot of times, if this is the patella located here, a lot of times it'll dislocate and come out laterally, dislocation over here, as long as it's bent. There really should never be a need for you to relocate those or reduce those at all. But if they are pulseless, you may have to. So that's an online medical control. You're on the phone and put them on speakerphone, have them walk you through. It's actually fairly simple though to do those ones. So fractures about the knee itself may occur at the distal end of the femur, at the proximal end of the tibia, or in the patella, like a patellar fracture itself. So easily to confuse with a non-displaced or minimally displaced fracture above the knee with a ligament injury. So a displaced fracture about the knee may produce significant deformity that makes it look like a dislocation, but it's actually a fracture as well. So continue to monitor distal neurovascular function, sorry, at least at the hospital. So you can kind of see that here where the fracture is. So located in that area there. So you can see the dislocation of the patella. So twisting may be enough to produce the problem. Just enough twisting can actually displace it as well. So injuries to the tib fib, as you can see here. This is very similar to the patient I just recently had within the last month and a half, except that was full circumferential all the way around, minus like one little small piece of skin holding it together, but completely separated right off, complete open fracture of the tib fib. But if you have open fractures, control bleeding. If you need a tourniquet, we tourniquet, but try to control bleeding without using tourniquet first. Usually both bones are fractured at the same time. Open fractures are usually the tibia are very common, where tibia being in front, so think of the toes, tibial bone comes here, right? And the fibula kind of runs out back that direction. Right, again, pedal pulses. If it's a fracture up higher, you can check tibial pulses as well, located right down there. But in this case here, I'm not going to check the tibial pulse because it'll be located here underneath the injury. So we're going to check a pulse up in the dorsal pedal pulse up top. So we're going to stabilize with a padded, rigid, long splint, right? The leg should be secured to the opposite leg and correct any severe deformity before splinting. So we have to move stuff back to kind of get it to go in line, and we can do that. Restore the position that will likely take a standard splint, sometimes associated with vascular injury. So be careful what's there, okay? Take a look at what you have before you start moving things back around. So cut off the pants, cut off the socks. Take a good look at what your situation is before you start moving stuff around. And realign the limb, which may restore adequate blood supply to the foot. So again, if it's cut off and the bleeding stopped, when you realign it to get pulses back, you may get bleeding back as well. All right, so be prepared for it. As far as ankle injuries go, we're almost there. Ankle fracture results from sudden forceful movements of the foot, right? So we'll have significant ecchymosis, usually pools up down low, as you can see in the photo, and travel its way up. So signs and symptoms of pain, deformity, and swelling. Axial load is transmitted through the foot and causes that talus to impact the distal tibia. So we get a potential of an ankle fracture there. One of the best methods to stabilizing an ankle, honestly, is putting a pillow splint on. Taking a pillow, wrapping it around, tying it off with 2 cravats, leaving the toes exposed for frequent distal checks in neurovascular function. But apply ice as well. But don't apply the ice packs directly to the skin. Wrap it around in the towel first and then kind of replace them in to kind of keep it cool. And elevate it to reduce swelling. To reduce the fracture or dislocation of the ankle, we need to make sure we relax the calf muscle by flexing the patient's leg at the knee and allow the foot to move more freely. Rotate the foot back into its normal position without forcing it. Right, it should be able to go right back into position. If you have to force it, then leave it where it is. Reassess distal neurovascular status in the splint. Splint the extremity in the reduced position. If unable to reduce the fracture, notify medical direction, provide rapid transport, and splint it as is. As far as foot injuries go, coming down to the very end of the body here, now result in a fracture of the tarsal metatarsal phalanges of the toes. Toe fractures are especially common. There's not much we're going to do for a toe fracture. They want to go to the hospital. They come to the hospital. The tarsal bones and the calcaneus, the most frequently fractured, especially with falls, heights landing directly on the heel. So the force compresses the calcaneus, producing immediate swelling or ecchymosis, as you can see here. But one thing you got to remember, though, is that pain and the potential for a pelvic fracture as well. So as they land down here, that force and drive straight up through the knee into the pelvis. So you may have pelvis and or lumbar sacral injuries as well. So if they fall down, don't rule out a spinal injury, right? If they land down on their feet from a significant height. If you suspect that a foot is dislocated, immediately assess the patient's pulse, sensory, and motor functions, the CSMs. The injuries to the foot obviously are associated with significant swelling, and vascular injuries are not really common with this. The lacerations of the ankle and the foot may damage the important underlying nerves and tendons. So taking a look at here, they're utilizing a blanket or a pillow, more like a blanket there, to kind of wrap around and keep everything stable and in place. We want to make sure those toes stay exposed so that way we can still check CSMs and transport the patient in a supine position. And to finish up with the amputations, with partial amputation, be sure to mobilize the part in bulky dressing and then splint to prevent any further injury. So if it's an amputation, we got to make sure we kind of partial, put it back where it needs to, almost where it needs to be, and then splint up and wrap. Do not ever sever any partial amputations. So if it's almost there, don't take out a knife and just start cutting away to finish it off. Okay, keep it in place. Control any major bleeding or shock. Obviously, cardiac monitoring, IV therapy, vital signs every 5 minutes. If it's a complete amputation, follow local protocols, preserve the amputated parts, get them on ice. All right. And obviously wrap them first before they go on ice. So put them directly on ice. Never warm an amputated part, and do not place an amputated part in water. All right, they're not flotation devices. So again, keep them on ice, cool, or there we can preserve the nerves and whatnot as well. Provide rapid transport to the appropriate facility. So contact medical control and say, hey, we have an amputated foot on our way to your facility. They may divert you if the patient is stable and divert you to a place that can do better surgery. I took a patient that ripped their thumb off in a dock about 3 years ago and brought them to a local hospital and then had to transfer them to Boston because the local hospital can't do microsurgery. So again, they may have you go to a local hospital initially to initiate transport, but if the patient's stable enough and you can make it down to a trauma center, they may divert you. Right, so make sure you let them know what level you're at. All right, and then sprains and strains to finish up in the last slide. General treatment is similar to fractures: rest, ice, elevate, right, rice. Compression with an elastic bandage usually helps as well. Reduce or protected weight bearing and pain management as needed. So strains and sprains are actually worse than fractures. They last longer with pain, but we just need to make sure they're getting treated. It's shut down here.